Good morning. So I'm going to talk about Russel-Silver syndrome. How many people here have treated patients with Russel-Silver syndrome? It's a very rare condition. I think I have the world's largest experience, not because of anything about me, but I have an endocrinologist at my institution who's the world expert. So I have seen all of these patients. And so I will share with you some of the patterns that we have. It's actually, in many ways, it's much more simple than other dysplasias. And so this is an example. This was my first patient I took care of. She came to me when she was 13 years old with a 5 centimeter discrepancy, predicted discrepancy of 5.2 at maturity. It was divided between the femur and the tibia. And so at that age, I lengthened the femur and I lengthened the tibia. The bone formation was actually quite excellent. She ended up with a leg length discrepancy. She ended up with equal leg lengths. And ultimately, what her overall situation is. What you'll see about these kids is that they usually are very, very small. They usually do not grow. They usually have nutritional abnormalities. But with human growth hormone treatment, delaying of puberty, and a very aggressive support system, you can actually get these patients. I mean, this girl who's 5'7", it's actually a miracle. And if you start to look up some of the pictures of RSS, you'll see what I mean. We published our experience in Journal of Children's Orthopedics a couple of years ago, and I'll just go through some of the some stuff about the syndrome. So it's an intrauterine growth retardation. These patients are born with small. Everything is small. They have difficulty feeding. They have postnatal growth retardation. Leg length discrepancy as well as short stature is present in more than 90% of patients. And bone healing would naturally be a concern because they are so, everything is retarded and slow, and so you would have concerns about that. Kids often require feeding tubes when they're little because they have difficulty with caloric intake. And there's really no specific data. Now, human growth hormone has been used very aggressively in these children starting at age 2. And that helps them with their short stature. But the idea of doing epiphyseal to correct leg length discrepancy doesn't really make sense in the setting of using human growth hormone to try to improve their stature. So the idea is that human growth hormone has been used, and there really have not been problems with it. It's actually been a very important part about the medical treatment of these children. So it turns out that the human growth hormone that is used to take care of these kids is actually a big advantage for us to be able to lengthen these children. And I'll show you what we have found. So when we started on this, we asked whether patients with RSS, Russel-Silver syndrome, treated with human growth hormone will have the ability to grow good bone, when you would normally think this group of patients would not make bone and there would be concerns about it. So what we did is we compared our experience to a group of general pediatric lengthenings that were patients that were congenitals, post-traumatic, and tumor cases. And so we did a comparison, and this gives you some of the information about the average age was similar, the amount of lengthening was similar, and the follow-up was similar. The crux here was that, look at the bone healing index, the RSS kids had significantly faster bone healing than sort of normal lengthening group in a group of pediatric patients. 29 days per centimeter versus 43. And that is counterintuitive. It doesn't really entirely make sense. So then when we we compared the RSS kids to congenitals, we found that RSS healed faster. When we compared them to our post-tumor patients, they healed faster. And when we compared them to the post-traumatic, like the growth arrest patients, there was no difference. So really, what we were showing is that the RSS kids did better than the congenitals and that they did better than the post-tumor patients. So in dealing with this group of patients, you're sort of grappling with the benefit of dealing with leg length discrepancy versus issues of bone healing. There's a scarcity of literature, but human growth hormone has been known to have a positive effect on fracture healing, but we weren't sure how it would affect distraction osteogenesis. There were recent animal studies that did show that human growth hormone had helped with muscle recovery and such. But what we did find was that all RSS patients had a good outcome. There were no significant problems. There was no premature consolidation with human growth hormone, and there were no complications related to the human growth hormone. The RSS patients had uniformly good healing. They were all on human growth hormone, and their bone healing index was significantly shorter in general than the pediatric population. And we believe that human growth hormone is really the reason that they had improved regenerate and bone consolidation. So I'll show you some examples. This is a girl who presents at age 8 with a leg length discrepancy of 4 centimeters divided between femur and tibia. This is kind of a typical pattern. They don't have a lot of deformity, and they usually have a sort of a relatively moderate pattern of leg length discrepancies divided between femur and tibia. So you can make a prediction about the leg length discrepancy. In this case, the predicted leg length discrepancy using the normal multipliers would be 5.3 centimeters. But one of the issues that I've learned with these patients is that the endocrinologist will keep them on they will delay their puberty. So instead of a girl ending growth at age 14, a girl will end growth at age 16 or 17. And because of that, you'll realize that your predictions are actually going to undershoot the actual amount of leg length discrepancy. And so that's one of the issues. So if I'm treating these patients early on, I will treat one bone, and in this case I lengthen the tibia, and my plan is to lengthen the femur in the future, and so I will do it as she gets closer to maturity. Again, the later you wait, the longer you wait, the more accurate you're going to be in this group of patients. Here's another example of a girl who presented to me at age 8 with RSS with a leg length discrepancy of 5.5 centimeters. And I think this case will illustrate. She had a predicted LLD of 8.5 centimeters, and I did a lengthening of 4.5 centimeters in her femur, and I achieved equal leg lengths. My plan was then to come back and do an additional 4 or so centimeters in her tibia as she developed the discrepancy. So I followed her, and at age 15, her leg length discrepancy was now 5 centimeters. This was just about the time that she had come off of the puberty delay, and you can see her growth plates are starting to close. And now I've got a closed growth plate, and so I actually used an internal lengthening rod. But if you look back at my predictions, the original prediction called for 8.5 centimeters of length discrepancy, and in the end it ended up being 10.5. And again, it's because this patient probably grew an extra year and a half compared to what a normal girl would grow, because they normally stopping at a younger age. I wanted to show a case of Ellis von Crevald syndrome that I had been taking care of since he was a baby, and I did an osteotomy on this kid, and my plan was to go and do his other side. And by the time I was ready to do his second side, the first one completely recurred. It immediately recurred. So I said, whoa, I realized this is not the way to go. And then I used growth modulation. You can see this case goes back a number of years. This predates the 8 plates. And so we use this. But growth modulation in this patient actually was quite successful at keeping these deformities at bay. And my plan ultimately was to come back and really fine-tune things as he got older. So this was growth modulation. You can see the staples turned into 8 plates. So you can imagine there were a few growth modulation episodes. But in the end, as a 15-year-old, this is what he looked like. Much better than he would have without the growth modulation, with a height of 4 foot 10 inches. And so at this point, I did my final procedure where I corrected his valgus. I lengthened him as well. And so we got him from 4 foot 10 to 5 foot 4 and got him nice and straight. Speaking about Ollier's disease, this is an example of a girl who had an arm discrepancy, and you can see with a large apex anterior deformity and a short right arm. And this illustrates what was brought up earlier, that you can lengthen these patients through the diseased bone. I used this multi-axial frame to both lengthen and correct the deformity simultaneously. And this is what it looks like at the end after the length and the deformity has been treated. And you'll see exactly that, and that is that the bone, the new bone that grew, there's new bone that is relatively healthy and normal looking that is between the proximal and the distal diseased bone. And so that is a phenomenon that is present in Ollier's disease. I don't know what to call this. This is an example of a radial club hand that is related to a dysplasia, some kind of dysplastic forearm. His radius is short. His hand is abnormal. He's never had a pollicization done. And so this patient was treated with an approach of looking at the problem and saying, well, the radius is short and the wrist is contracted. So we're going to lengthen the radius and we're going to gradually correct the wrist contracture. And so I did that with that type of approach. I used a talar spatial frame to lengthen the radius, and I used hinges to gradually correct the forearm. And so we went from a situation of that to that. We originally thought we might have to fuse the wrist, and we're thinking it would be unstable, but it turns out it was not unstable, and this ended up being a very, very durable deformity correction. And then I just want to follow up with an example of an achondroplasia case. You know, you get attached to these patients, especially if you've been treating them since they were little. So this is a different approach than what Dr. McKenzie showed. This was very much a stature lengthening approach. And so this is a little girl I met when she was about 6 years old. And so we did our first lengthening at age 7, and I did a bilateral femur and tibia, and we gained 5 centimeters. She actually did not have any genuvarum, this particular girl, but this would have been a good time to correct genuvarum if that was the case. The bone formation was excellent, and frames came off relatively quickly. Then at age 10, we did bilateral tibia lengthening, and we got 10 centimeters. Also, very, very excellent bone healing, and times and frames were very, very reasonable. So at this point, we're up 15 centimeters, but her arms are short. So we went back and we lengthened the arms. Many people will say, and I think I agree with this statement, that probably the most important functional operation that you can do on achondroplasia patients is lengthen their arms, because they actually have difficulty with perineal care. They cannot get down to their perineum to clean themselves, and this becomes a bigger problem as they get older. So we lengthened her arms. In the end, we did 7 centimeter bilateral humerus lengthenings, again with very, very good bone formation. And then at age 16, we were ready to do our bilateral femoral lengthenings. And this was, I would have loved to have used an internal lengthening rod on this patient, but the problem was her bones were too short for the smallest available internal lengthening rod. And so the approach we used was a lengthening over nail type of technique. I used a retrograde tibial nail, and I left the rod sticking out proximally so that it could be pulled into the bone. And what you see here is at the end of a 10 centimeter lengthening using lengthening over nail technique. And this shows the locking of the nails. Again, the bone formation in this patient was excellent. Very predictable, very, very excellent bone formation. So now, at the age of 16, she's 4'9". In the end, we've lengthened a total of 25 centimeters and 7 centimeters in her arms. And this is what she looks like, and this is her dressed for the prom. Very, very excited about that. So from age 7, Dr. McKenzie, you had mentioned that they normally get about 9 centimeters of growth between age 7 and 14. So she went from that, and we got her to a final height of about 4'9", 4'10". And I think it's important not to overdo it. You kind of have to just, I didn't go into this case with an absolute goal for exactly how much length I was going to get, kind of see how patients are tolerating the procedure. But in this particular patient, going through the process from start to finish, we gained an extraordinary amount of length with absolutely no functional deficit, no functional problems. Thank you for your attention.